Good afternoon and welcome to Population Health Subcommittee. Today is Tuesday, March 18th, 2025. And we'll now call to order. And Clerk, would you please open the roll up, please? Okay, Clerk, would you please close the roll?
Madam Chair Lady, you have 8 members present. You have a quorum.
Okay. Thank you. Welcome again to all of you. And at this time, I just want to ask if there's anybody on the committee that has any personal orders. No, not seeing any. Okay, we will move right on to our agenda for today. And we have item number 1, which is House Bill 1212 by Representative Johnson. Okay, we have a motion and a second. So your bill is properly before us. So please proceed with a brief description of your bill.
Thank you, Madam Chair. What this youth mental health bill does is it establishes a portal where any student K through 12 can request to see a therapist in their county. They can go online with their parent to make this request and be able to get several visits to a therapist because they are feeling like they need to talk to a therapist. And so what happens is they have those initial meetings, and after those initial meetings, if they determine they need more time or the therapist believes they need more time, then that is requested and they go through a procedure for that as well. But we know that mental health is a serious problem with our young people today. And, doing this in advance when they feel like they need the care, this will allow them to get that care and put off long-term and maybe larger problems in the future. This bill was modeled after a bill in Colorado. Colorado had they were one of the top states in the nation for suicide in young people. And so 2 years after passing this bill, it had a sunset on it, but they extended the sunset because what they saw for the first time in their history after passing this bill and it being utilized in all but 2 of their counties, they saw for the first time a drop in suicides in youth. And their suicide rate actually dropped in Colorado after 2 years of this bill being in place. And it's relatively inexpensive for something like this because it's just at request when a family feels that they need it. So this support will alleviate mental health issues in our youth and help grow into healthy adults and contribute to their communities. A lot of parents don't have the resources to get a therapist for their kids, and this program allows that free of charge for these families. We know that early access to counseling will destigmatize therapy for kids. It addresses attendance in schools. It addresses bullying in schools. When kids are healthy, they perform better in their academics. They also get into less trouble. They attend school better, and we see fewer bullying, fighting, all of those things decrease as well. So this is a bill, and we could pay for this bill from the $250 million that we put in a mental health fund. The interest from that each year that we spend on mental health would largely pay for this program. So just move passage.
Okay, committee. So you've heard the description of Representative Johnson's bill. Are there any questions for the sponsor? Chairman Clemens, you're recognized.
Yeah, thank you, Madam Chair. And I appreciate this legislation. As a longtime advocate for mental health care services in the legislature and joining, on both sides of the aisle on this issue. It's a really bipartisan issue. So I appreciate you bringing this and focusing on this. One of the things that I've been looking at and was shocked to learn over the past few years is the crisis facing young men across this country and across the state of Tennessee. Young men are facing higher rates of suicide, substance abuse, and they have lower rates of seeking help, unfortunately. And so I really appreciate this because I do hope, while every child, every young Tennessean needs access to mental health care, I would really like for us to figure out ways to make not only mental health care more accessible, but more approachable as an issue, especially for these young men who are facing these higher rates. So thank you for the legislation. I appreciate it. And can you tell us, kind of what your expectations are and what your goals for this are in the long run?
Absolutely. Destigmatization is a big part of it. And it does tend to be higher with males than it does with females. So you're exactly right. But there's something about if kids something that they could do as well. And, I've had kids as a teacher, I've had kids before come to me and say, I'm so angry and I don't know how to deal with this anger. And that's the kind of thing that we could alleviate because we know that is what leads to juveniles getting into trouble. And so for them being able to see someone early to learn how to deal with that anger is going to prevent so much. And it's going to prevent, when they've had that treatment as a young person, they're not going to be afraid of it as an adult. And especially when they know that it helped them. Because that's when you really can get to it and you really can help them when they're young. And what I saw, so many of the kids I worked with, because I worked with emotionally disturbed behavior disorder kids, they didn't have the tools in the toolbox to deal with their anger. And you can teach that. You can teach that to kids early. And it makes all the difference in the world. I can say that in my classroom, working with those kids that were there because they were behavior problems, I probably sent a kid to the office in an entire year, maybe 3 times. I didn't have to send kids to the office because we worked on dealing with those issues. We had counselors in the classroom, that type of thing, because these kids were certified. But there are kids in the regular class that could also benefit from this and need this help. And so it really is going to go a long way to making sure our kids' performance is better, that they're successful when they're adults, that there's less bullying, fighting, and all those distractions in our schools.
Yeah, I appreciate it. I mean, it's just, again, getting back to kind of the points I was making before with the societal pressures, the increasing isolation of young men, relationship issues, and the substance abuse issues that are facing our youth across the state of Tennessee. All those are factors that contribute to mental health problems. And so, again, while this would apply to everybody, I really appreciate you focusing on this and destigmatizing this, because I think the earlier that you have access to that mental health care, the more likely you are to not only grow healthy emotionally and as a person, but be more likely to seek that as you become an adult. And I think that's really important. So thank you.
And substance abuse is included in this as well.
Does anyone else have any questions for our sponsor today? Okay. Are y'all ready to vote? And Madam Clerk, would you please open the vote? Has every member voted? And does any member wish to change their vote? Madam Clerk, would you please announce the vote?
Madam Chair Lady, you have 2 ayes, 6 noes.
The bill fails. So we're moving on to item number 2, which is by Representative Johnson, which is House Bill 1217. Okay, the bill is properly before us, so would you please give a brief description of your bill?
Certainly, thank you. This bill would restore abortion rights to all Tennesseans. It reacts the Roe standard, the Supreme Court decision that was law of the land for 50 years, that the Dobbs decision gave us the right in states to protect women and do what is necessary and get the health care that they need. This bill would also eliminate any criminal penalties on people who perform or receive an abortion. Our current ban on abortion is extremely unpopular among people across the state. According to a poll conducted by Vanderbilt University in 2022, 80% of Tennesseans support legal abortion in some capacity. Additionally, the response to Tennessee's trigger ban was astonishing. Several thousands of Tennesseans took to the street to protest our nation's most strict abortion ban, further proving its unpopularity. This is an extremely personal and intimate decision that women have to discuss with their physicians, their families, their God, but this is a decision to be made between a woman and a doctor. And again, this goes back to the Rhodes Standard. The legislature is elected to enforce what our constituents are asking for, not our partisan interest or what constitutes this want to end abortion. A yes vote on this bill is a vote to restore freedom, health, and autonomy to women across the state. Women need to be able to determine when they start a family in conjunction with their family and their physician, not with legislators in Nashville. So this bill will just take us back where we have been for this time, women making the choice of when to have children.
Okay, we have heard a description of House Bill 1217. Are there any questions for a sponsor? Okay. Chairman Clemens, you're recognized.
Thank you, Madam Chair. I appreciate it, and I appreciate this legislation. You know, as you're seeking to return the law of Tennessee back to the Roe standard, I can't help but think about how Roe is rooted in the constitutional right to privacy. We talk a lot about individual freedoms and that right to privacy that's inherent in our Constitution, and so it seems like it would only follow that we uphold that constitutional right to privacy, and this entire issue is about freedom. And we also hear a lot about freedom up here. And the fact that women don't have the freedom to make their own healthcare decisions seems to me to be quite hypocritical for this body to enact and adopt laws that limit any American's freedom, any citizen's freedom, and tell people what they can and cannot do with their body in compliance with constitutional standards, or what was constitutional standards for over 50 years. And of course, you can't spell freedom without free, and we like to pride ourselves on being the land of the free. And so I thank you for this legislation and appreciate you bringing this to restore rights and equality, to make women equal to other citizens in the state of Tennessee. It's much needed. And so, if you don't mind, sponsor, can you just talk about the impacts that you've heard since we reversed the law, and what has happened since the Roe standard was overturned, and how that's impacted your fellow women across the state of Tennessee?
Well,
Representative Johnson, you're recognized.
thank you, Madam Chairwoman. Absolutely. And this is about freedom. This is about equality, because there's no question, if you don't have bodily autonomy, you are not equal. And so women in Tennessee are not equal because of these strict abortion bans in Tennessee. And what we have seen, we have seen OBGYNs flee the state because they know that they are at risk in doing what is required to save a woman's life. We know that there are women who have to go out of state for fear of bleeding out or getting infection when they have a miscarriage, and the things that cannot be done here in the state when a woman presents at an emergency room and cannot get the care that they need because a physician is afraid to give that care many times. And when we see in Tennessee a huge percentage drop of OBGYNs coming as residents to Tennessee because they don't want to practice here. One thing that we know about OBGYN or doing a residency in a state, you tend to, more than 50% of docs typically stay in a state where they do their residency. They build those relationships while they're there, and they end up staying in those states. And what happens if they're not coming here, when we already have more than 50% of our counties with no OBGYN, it's going to get fewer and fewer and fewer. And women and young girls are going to be less and less safe every year as we see the decline in numbers of these docs staying in Tennessee because of the risk of felonies and living in a state that forces a 10-year-old to carry her rapist baby. When you know that children die at 2 times the rate of adult pregnant women, and they could be an hour from the care that they need. We are setting women up to be at great risk. And this is not what Tennessee should be doing.
Chairman Clemens.
Thank you, Madam Chair, and I appreciate it. And you highlight a real problem facing the state of Tennessee right now with our maternal health care deserts, and there's a lot of factors for that. And in some parts of Tennessee, I think we had raised the alarm about the Henry County clinic closing several months ago, and women, in Paris, Tennessee, having to drive up to 2 hours just to get care. And and a lot of this shortage of OBs and others healthcare providers is a direct result of the laws of the state of Tennessee. I don't think there's any denying that, as well as other factors. And so I appreciate you bringing this legislation not only to ensure that freedom, but protect restore the equality in the state of Tennessee, because I think that's something for which we should strive every single day. And I appreciate you bringing this legislation. And, as you can imagine, as you probably picked up from my comments on your previous bill, I'm the father of 3 young boys. I wasn't blessed with a daughter, but if I did have a daughter, and I have sincere concerns about everybody else who has daughters in the state of Tennessee, I cannot imagine having a daughter in this state right now. And so I appreciate what you're doing for the young women and daughters of Tennessee.
Representative Johnson.
Yeah, for the first time in my life, I'm hearing from folks who don't want to send their daughters to the University of Tennessee or to school in Tennessee, to college in Tennessee, because of fears of this. I'm hearing from friends of mine who are musicians that are telling their friends who are traveling musicians doing tours that if you have someone pregnant on your tour, don't stop in Tennessee. You may not be safe. You may not be able to get the health care you need if you are on a Tennessee stop and you have a pregnant person on your tour. So the reality is people are considering other options with these draconian laws that we have in place.
Are there any other questions for Representative Johnson? Okay, seeing none, we are ready to vote. Madam Clerk, would you please open the vote? Has every member voted? Does any member wish to change their vote? Okay. Okay. Madam Clerk, would you please take the vote?
Madam Chair, you have 2 ayes, 7 noes.
Okay. House Bill 1217 fails. And we will move on to item number 3, House Bill 1220, which is by Representative Johnson. Okay, we have a motion and a second. So would you like to proceed with the description of your bill?
I think we have someone here to testify. Do we want to do that first?
Well, I think you need to present your bill first.
Okay. So this is a bill that just affirms right to contraception in Tennessee. Under this bill, every person will have a right to contraception or contraceptives that are, as it stands today, there's no law barring access to contraceptives or contraception. However, recent laws passed to ban abortion at all stages of pregnancy. Our constituents are concerned with their right to control their pregnancy decisions before conception and are concerned about that being inhibited in the future, because we have heard indication from members of this body in Tennessee, the legislature, and we have certainly seen it across the country where some of these rights are being revoked. And this is to be proactive and to make sure that we are protecting the right, not only the right to contraceptions, but also the right to affordable contraception and contraceptive methods in Tennessee. The ability to access and use contraceptive methods when desired is associated with reduced pregnancy-related death, improved infant health, higher educational attainment, and labor participation. Having access to contraception by age 20 significantly reduced the probability that women lived in poverty. Access to contraception helps women who rely on government assistance prevent pregnancy, which reduces the amount of money spent. It reduces unplanned, unintended, and adolescent pregnancies. Access to contraception allows women to pursue further education, participate in the workforce at higher rates, and increase their earnings. Publicly funded contraception reduced poverty rates for women who had access. I think it was actually Colorado that reduced their unintended pregnancy rate by 40% when they made contraception affordable for everyone. So it goes very far into making sure that we lower the number of unintended pregnancies. And that's something.
Okay, we've heard a description. Does anybody on the committee have any questions for our sponsor? Chairman Kumar.
Thank you, Madam Chair. Would you not agree that contraception is freely available to people at this time in the state of Tennessee?
Representative Johnson.
Yes, I actually stated that it was. However, there have been indications from members of this body that in the future, there will be some attempts to curb the use of some contraceptives. And we have actually seen it in other states that have very similar legislation to ours. We have already seen it happening.
Have any bills ever been introduced in this legislation restricting contraception?
Representative Johnson.
I actually think that there have been, but I can't name them right now, but I can find that out for you.
Okay.
But what I'm referring to actually is folks caught on tape from this body making statements about that happening down the road, just a couple of years after Dobbs. So we have heard indication from people in this body saying that that is something that they want to start doing. So all this does, if you're saying we already do this and we already have this, let's protect it going forward. It shouldn't be a problem to say that folks in Tennessee have a right to whichever contraceptive method that they want to use. And if we're already doing it, it shouldn't be hard to say that folks have a right to it if there's no other bills coming down the pike.
Thank you. Thank you, Madam Chair.
Thank you. Are there any other questions? Chairman Clemens.
Thank you, Madam Chair, and I appreciate it. And with regard to the previous questions, there have been conversations about limiting access to contraceptions in this body. And, I've kind of given up on trying to predict what next crazy bill we'll introduce up here or not. I never dreamed we would introduce legislation to deny education to children. So I think any bill that we pass to say that every individual has a fundamental right, I think that's the key to this legislation. And I think that's what's being overlooked. This says every individual has a fundamental right to make decisions about the individual's reproductive health care, including the fundamental right to use or refuse contraceptives or contraceptive supplies. That's the crux of this legislation. That's why it's important. We can head off any future crazy legislation that would try to deny individuals access to much needed contraception that protects health, allows for family planning, and just makes a hell of a lot of sense. So thank you for this piece of legislation. Appreciate you seeking to protect the freedoms and rights of individuals yet again. Thank you.
Representative Travis, you're recognized.
Thank you, Madam Chair. Question on the bill.
Okay, we have a motion.
What about, we're not
And
going
a-
to have the testimony?
We have a motion and a second. Question on the bill. All in favor? Okay, well, so we've got a motion and a second. Question on the bill. All in favor of the motion? That's exactly what I said. We have a motion and we have a second. So all in favor of Chairman Terry's motion, say aye. Or Travis, I'm sorry. Say aye. All in favor, say no. Or all against, say no. No. Okay, the ayes have it. So now we'll be voting on House Bill 1220. And we will go on the board for that. So Madam Clerk, will you please open the board? I'm certainly not. I live with one. Okay, would you please call the roll, Madam Clerk?
Madam Chair, you have 2 ayes, 6 noes.
Okay. House Bill 1220 is already dead in the Senate, and it has failed today. Okay. We have item number 4, House Bill 0945 by Chairman Williams. We have a motion. And we have a second. So the bill is properly before us. Chairman Williams, would you, you have some amendments, correct?
Yes, sir. Yes, Chair Lady. I do have 2 amendments. One is timely filed, drafting code 5689.
Okay, do we have a motion for amendment 5689 to be added? We have a motion to add amendment 5689? Motion. Is there a second? Okay. Amendment 5689 has been added and will, okay, all in favor, say aye. And all opposed? The ayes have it. Amendment 5689 is added to the bill, and you have another amendment, correct?
Yes, Chair Lady. It's an amendment to the amendment which you just adopted. However, it is untimely filed. That drafting code on that amendment is 5996. I'll stand ready. It omits a section of the previous amendment regarding storage of embryos.
Okay. Do I have a motion for item 5996, which is an untimely amendment to be added to the bill? Motion. We have a second. Okay. All in favor of adding amendment 5996 to House Bill 0945, say aye. Aye. All opposed? Okay, the ayes have it. We have the amendment 5996 added to House Bill 0945. So it is properly before us. If you would like to give us a brief description of your bill, Chairman Williams.
Thank you, Chair Lady members. Thank you, Chair Lady members. This bill as amended, if the body, the members remember last week, we had a long discussion regarding the topic of IVF. I brought amendment to the committee of which was discussed. As I discussed at that moment, we were trying to accomplish 3 things. One would be a certificate, as this new amendment does, certificate for licensure, which would not cost any additional monies to physicians that wish to perform ART, IVF, and as defined from the bill. It also seeks to license laboratories that do storage of those embryos for long-term storage with a performance bond in place for those laboratories in the event there is an error. This was worked on with the Department of Health to make sure that what happened in storage facility here and in other states doesn't happen, where the bond would stand to come in and maintain a facility that had frozen storage. This is the only component which would add additional cost. Third and finally, the original bill we discussed last week had a requirement that the Department of Health, the Attorney General, would, through promulgation of rules, set a model agreement between physician and prospective parents about the practice of IVF. In testimony last week, Dr. Hill from National Fertility Clinic made us aware that there were consent forms already existing. However, they were behind the paywall for licensed IVF physicians that the public cannot see. He and I discussed those consent forms, and I believe, as he does, that those consent forms are acceptable based upon them being the standard consent forms that the IVF practitioners currently use. And so the need for a model agreement to be developed from Attorney General and the Department of Health, because those exist, would be unnecessary. However, the only change that that would be to those consent agreements would be under this amended language that it would be there would be a prohibition on there would be no prohibition on genetic testing for chromosomal deficiencies or fetal fatal anomalies, which is currently a discussion that we had last week. And I heard from the committee and practitioners that this was an important component of IVF. And as I said last week, it's not my desire in any way to prohibit or deter or limit IVF. It's mainly to protect patients and prospective parents from someone who may be practicing ART without a license, which occurred here in Nashville last year. And so as this bill is amended, it does those three things. It uses a basis for the template for a model agreement based upon what IVF physicians currently do. It provides licensure for laboratories with a bonding component, and it provides for a certificate of licensure for those physicians who wish to practice ART or IVF. With that, I'm happy to answer any questions the members might have.
Okay, after hearing Chairman Williams' brief description of his bill, without objection, we're going to roll both of his amendments into one. Okay, at this time, does anyone on the committee have any questions for Chairman Williams? Chairman Kumar?
Thank you, Chairman Williams, for coming back again. You've been very open about the process and you have sought input from all sides. And I congratulate you and we appreciate it. So at this time, you mentioned about the boards and you mentioned about the matter of those who store the fertilized embryos. So those two bases are covered. Now, in your latest amendment, the limitation of number of embryos created and stored is removed.
Yes, yes,
Is
Doctor.
that true? Thank you. The last part about genetic testing, can you elaborate on that?
Yes, yes.
Chairman Williams?
Yes, Dr. Kumar. In the discussion last week, the original mandatory language had a complete prohibition on any testing as it relates to genetic testing. As discussed back then, I felt like that there were certain things that were acceptable to test for, and there were certain things that were unacceptable to test for. And in those discussions, this mandatory language, the byproduct of it is those discussions, which are chromosomal abnormalities and fatal fetal anomalies, which in normal existence and natural pregnancy, those generally speaking, most of those deficiencies in pregnancy would not allow for a full-term pregnancy to exist. And so because these are being fertilized outside the womb, I felt like that it was necessary for us to include those tests in this bill instead of a complete prohibition.
Thank you. Thank you, Madam Chair.
Thank you, Chairman. Are there any other questions? Chairman Terry?
Thank you. I just, could we just go out of session and have legal just give just a synopsis, since this amendment is obviously fresh for everybody, and I just need a legal synopsis so everybody knows what this bill actually does at this point in time.
Okay. Well, Chairman Williams, you have something before we go?
Just for clarity, Dr. Sherry, this the only amendment that was different or untimely filed was the exclusion of the frozen embryos. However, the amendment in its majority without that amendment was delivered to your office on Monday. Thank you.
Do you still want to go? Okay. Okay, we'll go out of session to hear from legal.
Heather Asbell, Legal Services. So I'll try to go over it briefly. So first, it prohibits a person to practice an assisted reproductive technology unless that person has obtained a assisted reproductive technology certificate from the board, from their respective boards, so either the Board of Medical Examiners or the Board of Osteopathic Examination. It then allows for that person to delegate tasks to certain individuals as long as it's within their training and scope. It has a compliance timeline, so a person would have 60 days after the rules become effective to be able to practice an assisted reproductive technology once the rules for the respective boards have gone into effect. The newer part that Representative Williams mentioned was the affidavit portion. And so a person would have to affirm by affidavit that they use the standard SART, Society for Assisted Reproductive Technology template consent forms. And in addition to those SART forms, the person would have to consent that there's a prohibition on genetic testing unless the genetic test is for chromosomal anomaly testing or fatal fetal anomaly testing. The untimely filed amendment that was adopted today in committee took out the portion of the limit for how many embryos could be cryogenically stored. So that portion is removed. So it's just the genetic testing, unless it's for those two anomalies, and have to have a clear understanding of an informed consent regarding the custodial care of unused or abandoned embryos. And so then that replicates that in the Board of Osteopathic Examination part. And then moving into the fertility clinic portion, it requires each fertility clinic operating in the state to obtain a certificate to use assisted reproductive technology. They also have a compliance timeline. They also have 60 days to comply with these rules once 60 days after the rules become effective. The Department of Health is allowed to create a certification, create minimum standards, conduct annual inspections of the fertility clinics, and each fertility clinic has to give the department access to certain things that they deem is bearing on whether the fertility clinics operate in accordance with this part. And then the department has several different authorities, which includes denying an application, suspending it, permanently revoking, or refusing to renew a fertility clinic certification. And then there's a reporting requirement as well. Each RE1, the medical director of each fertility clinic has to report to the CDC and to the department certain items that are listed. And then if the medical director fails to report, they may be suspect to disciplinary action. And that is generally what it does.
Okay, has anybody got any questions for legal? Chairman Clemens?
Yeah, thank you, Madam Chair. So the case in Nashville was referenced, and I don't know all the facts surrounding that case, but from what I understand, it was unexpected closure, and the families who were using that facility were left in limbo because of unexpected closure and a lack of communication from that practice. Does this bill do anything to prevent unexpected closures of a clinic, even if a person is properly certified?
The bill doesn't directly speak to that. I did forget to mention in my synopsis, there is a bond requirement, and I apologize about that. There's a bond requirement that each fertility clinic has to post specifically for the storage of embryos. But I don't know that case specifically, and I fear it's ongoing, and so I don't want to comment on an ongoing case.
Chairman Clemens?
Thank you, Chair.
Does anyone else have any questions for legal? Okay, while we're out of session, we may go ahead and hear from testimonies. Do we have a Dr. Christopher Montville here? Okay, and Molly Walker and a Kara Edwards. Okay, if you all don't mind to come up here and take these 3 seats. And we can start with Dr. Christopher Montville and go down. And if you'll just care to state who you are and who you're with. And we'll give you 3 minutes to speak, okay? Each one of you.
Thank you, Madam Chair and Representatives. It's a pleasure to be here today. My name is Dr. Christopher Montville. I'm Medical Director of Tennessee Fertility Institute based out of Franklin. We serve patients from Memphis to Johnson City to northern Alabama and southern Kentucky, so a wide swath of land trying to help patients build their families. I'm going to build a little bit on what Dr. George Hill presented last week, but today I want to speak more towards the personal side of IVF medicine. And my concern and opposition with this bill is the broad sweeping language that may limit access to care and ultimately hurt patient outcomes. IVF is not a one-size-fit-all kind of medical practice. And when we use terms like normal embryos, talking about genetic testing, it's much more delicate and intricate than that. A woman at age 35, for example, 50% of her eggs have abnormal chromosomes. That means 50% of those embryos are abnormal and would not be viable. PGT testing does not tell us if an embryo is healthy or normal or viable. It helps us screen those embryos to transfer first. Age 40, it's an 80% abnormality rate. So when it comes to genetic testing, broad language, including PGT and specific genetic screening for fetal fatal anomalies, that covers a wide scope of single gene mutation disorders. There's no current standard practice of doing genetic screening for hair color, eye color. That's not in standard practice in IVF clinics. So I think in this bill, that wide sweeping knowledge may limit then the available tests that could be there for patients to use. And then lastly, I think importantly, when you think about the intricate detail of these conversations that we have with our patients, in order to become a board certified reproductive endocrinologist, I have 17 years of post high school graduate training and 16 years of clinical practice. And every single day, I have to work very diligently to have careful conversations with these patients. And my concern is that with broad sweeping language in any legislation regulating IVF, that those conversations may be hindered. And again, the access of care to my patients is going to be harmed.
Thank you, Dr. Montville. I think who's next, if you would like
Oh,
to
Thank you, Madam
state.
Chair.
We'll have all 3 of you
Okay.
speak, and then we'll see if anybody's got any questions at the end.
Okay.
So if you just state who you are and who you're with.
Thank you, Madam Chair. My name is Kara Edwards. I am the founder of Starfish Infertility Foundation, based here in Tennessee. We are the only 501c3 in the state that raises funds to fund fertility treatments for couples that are needing treatment and wanting to grow their family. I am also the proud mom to twins who are born from IVF. They are my miracle babies. Unfortunately, we've been talking about this other clinic and it closed. I am one of those patients. I have my own horror story with that clinic. So I think what bothers me the most about the portion of this bill regarding the clinic is the testimony from last week and then this week as well, that wouldn't have prevented what happened. So I think what that tells us is we still have a lot of work to do. Because right now, the way this bill goes, we're talking about more restrictions or just regulations that are going to do nothing but cost me as a patient more money. Infertility IVF treatment is already outrageously expensive. I have a disease. I have endometriosis. I have a disease. My insurance doesn't cover it because my insurance says I don't need a child to live. So they don't need to cover it. Now I can smoke my entire life and they will cover my lung cancer, but they won't cover this. So I'm forced to pay for it out of pocket. So anything that's going to affect what I have to spend in my treatment means a lot to me. I won't go into the frozen embryo part of it because I will, Chairman Williams, I will applaud you and all of the rest of you that have had the conversations for withdrawing and amending that part. That was very, very important. And I'm very thankful that you listened and you pulled that out. That means a lot to us. So all I'm saying is Dr. Montville has talked about the abnormalities, and it just tells me, listen, we have reduced, it's a 7-page bill about clinics, and we have reduced the talk of the embryos down to one line, one sentence. It needs to be more of a discussion than that when you're talking about how vast this is going to affect people here in the state. Roughly 17% of your constituents have an infertility diagnosis, and this will affect them. So can we at least back up for a second and just spend some more time talking about this? Let's spend the time that it truly deserves. I just don't think that that's too much to ask. So thank you all so much for your time.
Thank you, Ms. Walker, or Ms. Edwards.
That's
Right. Okay. Now we have Molly Walker. If you'll state your name and who you're with.
Yes, thank you so much, Chair Lady Carringer. My name is Molly Walker. I am the co-founder of Tennessee Fertility Advocates, and I just appreciate the opportunity to speak with each of you today. Again, I am here as an advocate for Tennessee families who have relied on IVF to build their families. I am also very proud that our grassroots organization represents thousands of infertility patients across the state and beyond. And it has become the largest grassroots organization in the U.S. And this is so near and dear, not only to my heart, Kara's, Dr. Montville's, but there are thousands behind the scenes in your district that are pleading and begging for you to just do exactly what they've said. Take time to really process what this piece of legislation would do. For Tennesseans, many Tennesseans, IVF is not a luxury. It's the only path to parenthood after years of enduring infertility, pregnancy loss, and true heartbreak. This amendment, while well-intended, introduces restrictions that could limit access to IVF and place unnecessary burdens on patients and providers. Prohibiting genetic testing of embryos at any level is unethical. And the detrimental cause to that, I think, is truly beyond the scope of what is referenced here in this bill. I won't mention about the embryo storage since we just found out that that piece has been removed. But these are real people. These decisions that you're voting on are families who are just people that are trying to have families. And so I urge you, just as a mom myself, someone who's had 3 miscarriages, numerous thousands of dollars in treatments, I am pleading with you with everything in me to just take time and to just give this bill more consideration, because we have thousands of people who deserve better than this in our state. So I thank you so much for your time. Thank you for the opportunity to speak, and especially Dr. Montville. He is an amazing, amazing doctor in our state, and just very thankful.
Thank you to all 3 of you all. Right now, we'll see if there's anyone on the committee that has any questions for any of our 3. Dr. Kumar.
Thank you, Madam Chair. Thank you all of you for coming here. You opened your personal lives and stories to us, and we learned from it. I could ask the question to any of those, but I'll start with Dr. Montville. Is genetic testing a routine part of your practice?
Dr. Montville, you recognize.
Thank you, Madam Chair. Yes, Dr. Kumar, genetic testing is a large part of our practice. Roughly 80% of our IVF patients use pre-implantation genetic testing.
Chairman Kumar.
Is the choice up to the patient?
Dr. Montville.
Yes, sir, it is.
It is. And is cost a major factor in that?
You're recognized.
Cost is certainly a factor for almost every patient. Thankfully, insurance is covering more of the cost of in vitro fertilization in the state of Tennessee. Looking at our numbers over the last year, roughly 68% of our couples that used IVF had some sort of insurance coverage. Pre-implantation genetic testing is often an exclusion from a couple's insurance coverage, and so those patients will then often opt to pay out of pocket for that service.
So what do you offer? What do patients use genetic testing for? What is covered in that?
Genetic testing platforms have really changed dramatically over the last 10 to 12 years. The primary use of preimplantation genetic testing is for chromosomal aneuploidy, which means an abnormal of chromosomes within the embryo itself. There are 23 kinds of chromosomes. We get one copy from each parent. As eggs get older, they tend to have more abnormal copy number. That's why I raised the issue of 50% abnormality at age 35, 80% at age 40, upwards of 90% by age 42. And those directly correlate to then abnormal embryos that would not result in a healthy live birth. So PGT, as we use it currently, is mostly recommended for women 35 years of age or older in order to screen the embryos to find the ones that have the best potential for pregnancy. Dr. Hill mentioned last week that just by looking at an embryo and looking at the embryo grading, one can't tell if the embryo will result in a healthy baby or not. Even in the instance of having a PGT chromosomally normal embryo, all we can screen for is the number of chromosomes. There's so many other biological factors that have to fall into place to then result in a healthy child. And that's why even with PGT, quote, normal embryos, we still see 35% of transfers will be unsuccessful. And that also continues to go down as the age of the female partner starts to go up. So a 40-year-old with a chromosomally euploid or normal embryo has about a 50% chance of implantation compared to a 65% chance if that woman is younger. So that's the indication for PGT, where we think we can identify the embryos that have the better potential, thereby helping couples get pregnant faster, because now we're not doing unnecessary embryo transfers, which can be quite expensive. Importantly, we're avoiding miscarriage. 1 out of every 5 clinical pregnancies naturally will result in a miscarriage. With PGT, that risk is 5 to 10%. So now we can save women the heartbreak of then having that pregnancy loss to hopefully build their family in a more expedited fashion, avoiding heartbreak, but also from a financial standpoint where they're not going through unnecessary treatment after unnecessary treatment.
So with genetic testing, if you get a result that says that there is chromosomal abnormality, is that an automatic disqualification for use of that embryo?
It depends on the abnormality. For most testing platforms, we could get a readout that says that the embryo is truly aneuploid, meaning it has an abnormal number of chromosomes that would not result in a live birth. But no scientific test is 100% accurate. The testing we currently have is about 98% accurate, but the other limitation is that we may see what's called chromosomal mosaicism, where if we biopsy 6 cells from the outer ball of cells that forms the embryo, that those cells form the placenta, those are the cells that we're taking. You could have 4 cells that have normal chromosomes, but 2 cells that have abnormal chromosomes. So we would say that that embryo is a mosaic embryo. But the percentage of cells that have abnormal chromosomes is low compared to those that have normal chromosomes. So we use the term low-level mosaic. We then have our patients have a visit with a genetic counselor about the reproductive potential of those embryos. Those embryos can still result in healthy babies, but the implantation rate is approximately 20% lower. But the opposite could be said. You could have 4 abnormal cells, 2 normal cells. That would be a high-level mosaic embryo. Those embryos tend not to result in a healthy pregnancy. As patients go through the embryos that they have, we do counsel them about the option to transfer those embryos if they have adequate counseling and informed consent.
Last question, thank you. So the testing that would be allowed by the amended form of House Bill 945, is that sufficient to allow for good, safe practice of IVF?
I think the language in the amendment is too broad because there are several mutations in the genetic code that can result in fatal fetal anomalies. There are many fatal fetal anomalies that just happen, what we use the term de novo, during gestation, where these babies may then incur a genetic anomaly. So I think by just having that blanket term, fatal fetal anomalies, what all might be included in that? We have some patients who have a family history of Huntington's chorea, for example. Well, those patients can then suffer debilitating illness as they get older, and there are some families that don't want to pass that down into their family line. That wouldn't be considered a fatal fetal anomaly, but in the language of this bill, that testing would be excluded because it's not a fetal anomaly. There are other certain genetic conditions that can impact us as we go into adulthood. Certainly some may have penetrance or They arise earlier in one's life, but devastating consequences that can impact a whole family line are instances for which we can test. And so I think in the current language, it's too broad. And one might then question, well, can I test for this test or can I not test for this one? And that's again to my point that it really takes these in-depth conversations with our patients to really try to have them understand the implications of these tests, but also the implications of that disease state as well. I think those conversations are better left to a physician and their patients.
Last time for the last question. So one is, that's the second part of my question, really kindly tell us what do you mean by broad language. But when we are dealing with the situation of genetic testing, does this not give us too much information, more information, or same information as a person who is undergoing through pregnancy, is maybe older in the years, and genetic testing is prescribed, even with a natural pregnancy? As we compare it, are we restricting any tests that would be available to that mother who is not under the IVF umbrella as compared to what we're allowing here?
I think the primary difference between in utero testing, so testing that's available for a mother who is already pregnant with a child, is it's kind of a before and after the fact. And that's how I delineate testing with IVF compared to testing with a pregnancy. Once a woman is pregnant, standard recommendations from the American College of OBGYN is to offer chromosomal aneuploidy testing, which is a blood test that the mom receives to look to see if her fetus may or may not have an abnormal chromosome number. And that's how a majority of babies with, say, a trisomy 18, for example, or a third copy of the 18th chromosome can be diagnosed. Well, at that point, those babies typically tend not to survive to birth. They often will expire in utero, or if they are born, they may have severe debilitating illnesses. That testing is done after the fact, after the woman has become pregnant. With in vitro fertilization and preimplantation genetic testing, we can identify the embryos that would have that trisomy 18, and then the patient then would have the option of whether to transfer that embryo. But if she or he are then able to identify that embryo, they then would have the right to elect not to transfer that embryo, knowing that if they did and if they got pregnant, they would be facing a horrific pregnancy, fetal death, and the heartache and the expense and just the demoralizing impact that could have on their families. That, I think, is one of the great benefits of preimplantation genetic testing, avoiding unnecessary complications, using science to our advantage, where, again, we're not testing for eye color or hair color. We're looking for either known genetic mutations that run in families, or we're looking for chromosomal issues before pregnancy. And that's where we can really help our patients achieve their dream, which is actually a healthy live birth and a healthy child that then could have a healthy life ahead of them. So in my mind, those are the two differences: in utero testing, which has its limitations because the woman is already pregnant, compared to preimplantation genetic testing, which is done before embryo transfer.
Sorry. So in utero pregnancy, genetic testing, well, let me put it another way, is this genetic testing so thorough and much better and much more informative than the in utero genetic testing? It has the luxury of getting a lot more information.
That's a great question. Is the genetic testing as thorough with PGT as it might be in utero? Is that the question? Two different aspects when it comes to genetic testing. One is for chromosome abnormalities. So the chromosomes are the structures that carry our genes. And with the in utero testing, the testing is still quite good, even a little bit better, 99% of finding if a fetus may have an abnormal chromosome number. But 98% with PGT, 99%, they're quite equal, in my opinion. But even with the in utero testing, there is a slight error rate. No test in science is 100% accurate. If there's an abnormality on the in utero test, then the patient has the option of having an amniocentesis for definitive diagnosis if that is present. So that's chromosomal screening. And that is the risk that increases as women get older facing pregnancies. The other kind of screening, though, is genetic mutations, specific gene mutations that can then lead to things like Huntington's, chorea, or cystic fibrosis. There's no magic test. And I often joke with my patients, I wish it was like Star Trek, where we had a little ray gun and we can go and find the embryo to see if it has an abnormal gene mutation. There's no test that's like looking for a needle in a haystack. The couples who come to us for help and counsel are those who have a family history of these devastating genetic diseases, or they may have a child that was born with a disease state, then did post-delivery genetic testing. Now they've identified that specific gene mutation. Then we screen both partners for that specific gene mutation that now we're looking for. So unfortunately, the genetic testing isn't specific enough to find many different genetic mutations that could be present. We're looking for the specific mutation that's falling in the family or that's been newly diagnosed.
Dr. Martville, thank you for educating us. We
That's
really
my pleasure.
appreciate it. Thank you. Thank you, Madam Chair. Sorry to take so long, but it was
That's quite all right. Does anyone else, Chairman Terry?
And thank you. And Dr. Kumar asked a lot of my questions about, I was going to ask about the way that this bill is currently structured, what you could not do versus what you're currently doing now as far as the testing goes. But and that gives me to the next question would be, so in this version, you would not be testing for Huntington's or something that's not fatal, correct?
That's correct.
So currently, if you are testing, what happens to those embryos?
We have an embryo disposition form that we fill out and go over with all of our patients. Whenever you're freezing embryos, sperm, eggs, we have an embryo disposition form, which is essentially an agreement that the patient fills out directing us as the clinic on how they would like their embryos or genetic tissue to be handled. That could be long-term storage. That could be if you have a chromosomally abnormal embryo that would not survive to a term birth, they could discard those embryos. What it would happen in the event of divorce, death, those kinds of things. So if you have an embryo that may have a severe disease like a Huntington's, it's up to the patient's discretion as to whether they would then discard those embryos, keep them indefinitely. There are also some options throughout the United States of donating embryos for stem cell research, where they could then learn more about these different genetic conditions. But we ultimately leave it up to the patients. Certainly encourage good genetic counseling about what these conditions are, but it's ultimately up to them to decide the ultimate disposition of those embryos.
Does anyone else have any questions for our panel while we're out of session? Okay. Thank you all very much. And we do have Department of Health, but I don't, Chairman Terry, we're still out of session, yeah. Oh, okay. Chairman Terry does have another question for Dr. Montville. Okay.
My apologies. The certification, the ART certification, is that something that you could comply with, or how would that impact your practice?
The question is regarding ART certification from a state level.
Yeah.
I do agree with Dr. Hill that the certification requirements of this bill are redundant in that as far back as 1992, with the passage federal regulations that every ART clinic needs to report their data. So that's been in effect for over 30 years. That I think then taking that to the state level adds a level of redundancy for the clinics, for the staff, but also for the state in general. From a certification standpoint as physicians, one has to be licensed as a medical physician to practice medicine in Tennessee. And that delineation in terms of which specialty to practice then comes from national board certification. As Dr. Hill mentioned last week, we're board certified in both obstetrics and gynecology as well as reproductive endocrinology and maintain yearly maintenance of certification. So I think that's done at a federal, local level. If we're adding that to the state, again, it's a redundant system. Lab inspection from the College of American Pathologists, or CAP, that's done on an every 2-year basis. The Food and Drug Administration will often have lab inspections on kind of a surprise basis, where it's not announced when they're going to be evaluating the laboratories. So whether or not the state would then take on evaluation of the labs. One concern I have is who would be doing the certification and who would be doing the inspection from a state level. Reproductive endocrinology is such a specific field in obstetrics that one would ask the question, are the inspectors qualified to inspect an IVF lab? Whereas from a national level, CAP inspectors are typically lab directors, PhD scientists who work for the College of American Pathologists who go all over the country to inspect different labs. So they could be in Seattle one week, New Hampshire the next. And so I often wonder what then is the criteria for lab inspection from a state level? And importantly, how good is the inspection that you're getting? When with CAP, we know that it's a national certification, people who run their own embryology labs and come in and inspect other labs. And so that's another concern that I have with the level of certification in this proposal.
Thank you.
Anyone else have any questions while we're out of session? Okay, everybody good? We're going back into session? Okay, we're back in session. Again, thank you all very much. Chairman Williams?
Thank you. Just as a follow-up to some of the discussion today, I just want to make sure that I thank Doctor and the advocates for being here today. As I said last week, there's no desire in my mind or heart in order to limit IVF. However, there was some discussion about the clinic here in town. This certification, albeit by our doctor's testimony being redundant, I think it's necessary because in the instance, I've had an opportunity to speak to a patient who was a patient of the physician who closed their doors abruptly, and they had no licensure in order to do that. They, from what I'm told by the patient, and they, when asked who was the physician overseeing his practice, no name formalized. And so what this would do, much like I had to do last week when my wife had emergency surgery, I looked up on the website, the Department of Health, and found that the surgeon who was performing the surgery on my wife was actually a licensed Tennessee physician. That would be it would be possible to do the same for ART for Tennessee because of that certificate, although it being redundant. I heard from patients, friends, neighbors, and this committee regarding some of the concerns that they had, and the discussion about it being broad sweeping is kind of dependent upon one's view. To me, it seems like it's very broad for a reason, because there's nothing here in this bill now that would prohibit anyone from doing those genetic tests that, quite frankly, aren't available to a traditional pregnancy because of the nature of the challenges associated with not just these patients and their families, but also the eggs and sperm and embryos in which they work with. And so in relation to the laboratory, the reason for the inspection would be done by the Department of Health, who currently does laboratory inspection here as well. I think they're qualified to do this laboratory inspection based upon the federal regulation or standard as it relates to laboratories. I think it's important to do that. Another reason for having the certification of the laboratories is much like here in Nashville. What occurred, the Attorney General had to step in and get an injunction to come in and get in the embryo storage freezing business in order to preserve those embryos that those families have pinned their hopes and dreams on and made large investments. This would allow the Department of Health to immediately go in and take over if that were to happen in that case. And so I do think there are a lot of redundant things, but that was the part of it is being redundant is because we do have federal statute, and we're trying to mirror that federal statute in every area that we possibly can in order to make sure that these patients get the kind of resources that they need. They're informed about testing. They're informed about storage. They're also informed, as he said, about what happens when there are abnormalities with eggs, sperm, or embryos, and how they're discarded and what the patient wants to do. All those consent forms are part of what their practice currently does. And so I feel like it's incumbent upon us to make sure that we have just a simple redundant process that allows for certification of a physician and a laboratory, so that later on, if there is another challenge like we've had or has happened in Alabama, that the courts aren't deciding, that this legislative body and the citizens are deciding as to how to best handle the challenges that might occur around ART. So with that, Chair, lady, and members, I'm happy to answer any other questions the members might have.
Okay. Does anybody have any questions for Chairman Williams? Department of Health is here. We can go out of session and hear from them.
Thank you, Chair Lady. Holt Witt, Department of Health.
You have a question, Chairman Clemens?
Yeah, thank you, Madam Chair. So got several issues with this legislation, but with regard to the testing and inspections, can the Department of Health speak to that, whether or not you have any qualification whatsoever? I know a lot of this stuff has been handed over to the Health Facilities Commission for these inspections, for which they're wholly incompetent in most cases. So does the Department of Health have this competency, and is it prepared to take on the inspections?
Thanks for the question. We indicated a fiscal review, we would need additional inspectors to comply with the amendment as drafted. Obviously, they haven't looked at the most recent amendment since it was just filed, but we did indicate that we would need inspectors to help with the caseload associated with implementing this bill.
Thank you, Madam Chair. So currently, the Department of Health does not have that level of expertise or competency to do something that the federal level is already doing.
Thank you for your question. Currently, we are contracting with Health Facilities Commission for the med lab inspections that are currently conducted by the department, because those positions transferred over to health facilities when they split from the department. We're in the process of hiring med lab inspectors to be in place when that contract ends, and then this would allow us to also hire additional inspectors that could specialize in this certain type of laboratory.
So it's a no.
We currently contract with Health Facilities Commission because they have the inspectors that were currently at the department. We anticipate having inspectors in place before that contract expires to take over those duties.
Chairman Clemens?
Yeah, well, I mean, that raises a whole nother level of concerns. I mean, I can give you a laundry list of things and expertise and parts of the healthcare industry that have reached out to me with concerns about the knowledge of what's going on at the Health Facilities Commission. So that's a whole nother issue. So thank you very much.
Chairman Terry?
Thank you. Thank you, Chairman. And thank you for coming. I do have a question on, I'm just trying to wrap my head around the process, and it talks, with the rule promulgation for the certificate, and then these clinics have 60 days to comply. Is that turnaround time something that can be done?
We anticipate that they could comply with the certification process in 60 days as it's drafted. As this amendment has been worked on, we've been talking with Chairman Williams about the best way to implement this, and that's been our main objective with working him on language, is trying to understand what direction he'd like to go in and how the department could best set something up should this pass. And so we believe that, yes, a clinic or physician could start the certification process within the 60-day timeline, especially for the physician to get them certified. And then we would put them on a list to be inspected, after that for the facilities.
So I guess my question is if this were to become statute, the issue would be about a delay in the services from the clinic. Would there be any delay for them getting this certification? Would they be, out? Would the patients be out because of a delay to get the certification?
I don't know the answer to that. I think we think we could handle an application within 60 days, but I don't know if there would be a delay, and I'd have to get back to you.
All right, thank you.
Does anybody else have any questions for health while we're out of session? Okay, seeing none, thank you, Mr. Witt, for being here. We're back in session. Chairman Williams. Has anybody got questions for Chairman Williams? Chairman Clemens.
Thank you, Madam Chair. I've got real concerns about this genetic testing and being limited to the fatal fetal anomalies, as the doctor pointed out, and what the restrictions of that are with regard to what is a fatal anomaly, which isn't. So did you intend to exclude those things? And if so, why? And if not, that's perfectly fine too.
Thank you, Chair Lady. Chairman Clemens, the goal here was to try to find a solution that I felt like that mirrored what we currently do in a natural pregnancy. But this goes further than that. And I also, in discussions with other folks, there are certain things that I feel like I've got a call from a children's hospital. And the question is, are you okay with testing for predisposition of cancer? There's no, you can test for predisposition of cancer and not, in fact, ever get cancer. It's a predisposition. So there has to be a line drawn somewhere, as mentioned by the doctor. They don't test for sex or eye color or hair, but those are the byproducts. Most of that information you can find out, or you can find out downs through chromosomal testing. And so the goal here really is to try to find a solution that is workable under the guidelines that they're currently operating in. And in most instances, if it were a natural birth, you probably wouldn't terminate a pregnancy for a predisposition to cancer or Huntington's. Some may wish to or want to, but the goal here was to try to give them the similar resources that they had here as well, but not get into things as it relates to eye color and hair, which with enough resources, hair color, with enough resources, you could probably do that. However, and which is why I changed the whole testing of embryos altogether. There's no prohibition at all on testing eggs for whatever you want to. This has to do with embryo testing. These limitations are all on the embryos. So in the instance of a 35-year-old or a 40-year-old, and they're testing to see the viability of the eggs that they've retrieved, that there's no prohibition on those tests. This is a prohibition on the embryos themselves.
Chairman Clemens, you have any?
Yeah, thank you, Madam Chair. I guess trying to just, based on what you said, it seems like you were intentional about this language, and you referred to it, I think, in your initial remarks as consequential language, which I appreciate, and I know you've done a lot of work on this, and I appreciate you amending the amendment. I think that was a positive step forward. But so, what, if any, healthcare organizations, doctors, or otherwise produce this language or endorse this language within this field? Have any?
I'm sorry, Chair. I'm not understanding
So
the question.
you said you did a lot of work and you came up with this consequential language. So I'm trying to figure out or identify from whom did this language come?
Oh.
Did any healthcare organizations who are specialized in this area endorse this language, or healthcare providers specifically?
Thank you. In discussion with, there are some healthcare providers, ART physicians that I have communicated with. I've talked to legal counsel that represents most of the people in the room that have to do with IVF. We had a great discussion about that, but the tenets of the bill reference the minimum standard as it relates to what the CDC has set forth. And so if the practitioners of ART across the nation are fine with the CDC minimum requirements, which is what this bill references, then they should be okay with this. I think the big challenge in any change that you and I may have as it relates to legislative change is it's different than their current practice. And when it comes to ART, particularly IVF, this has been around for 45 years with real no controls other than suggesting controls from the CDC. And in most cases, every person that I have communicated with are not only meeting those minimum standards for the CDC, but exceeding them. So to use the doctor's example of it being redundant or paralleling is really all this bill seeks to do, except for the notification about that people have an opportunity to put their embryos up for adoption instead of, as he discussed, discarding those or having the doctor discard those, because currently they're seen as personal property. And so what I'm trying to do with that, and with also the embryo, the testing, is to try to find a Tennessee specific way of maintaining and delivering this healthcare model for these parents who want to have children, these prospective parents. And I believe this bill does that. So I hope that answers your question.
Thank you, Madam Chair. Thanks, Sponsor.
Okay. Chairman Terry, you're next.
Yeah, thank you. I do appreciate the sponsor for bringing the legislation and your work on this, and listening to folks to try to get this in a place that something that we could work for. And I appreciate the conversation and the thought that you have put in this, and and there are some issues that you bring forth that I do think probably deserve more discussion and maybe some resolution. I am really struggling with your bill. I mean, this is, and I've been in this room talking about moral foundations and with me internally, and this is something I'm really struggling with. But a year ago in this committee, it was either I was in this chair or this other chair, and we had a bill come up dealing with contraception and IVF, and I made a statement that there weren't any threats to IVF or to contraception as it currently stands. And so the issue that I'm struggling with is that here we are within 1 year, and then I'm being asked to go back on my word on something that I said that I had, the reason we didn't need a bill last year. And so for that reason, I'm not going to be able to support your bill, but I do want to carry on with these conversations.
Chairman Williams.
Thank you. Thank you, Dr. Terry. I appreciate your point of view. I think as you referenced about my work here, I don't think this bill impugns or limits IVF in any fashion unless you wanted to test for Down syndrome, or you wanted to test for Huntington's or predisposition of cancer. Fact is that CDC sets the minimum standard, and this bill meets that. And it's a licensure component. My fear is without action from this body that the courts will decide as it relates to what happens with IVF because of what's going on in Nashville with someone who was not licensed physician, not practicing within the minimum standards, and abandoning the investment that these people in this community made towards being able to have children. And so I think without action of this body, regardless of whether it's a year from now or 10 years from now, I feel like that with not having the correct oversight and sustainable control of this, that it will continue to be an unregulated, unmanaged healthcare system that it's been since the early 80s. And as more and more physicians who have been practicing IVF and ART for more than a decade begin to retire, like one that's doing in Nashville, then we're going to have discussions, and this would be the basis of that. We're going to have discussions about what this state views unused embryos, or the discarding of those embryos, or make decisions about whether or not these are extra uterine pregnancies like they did in Alabama. And so without some kind of structure, my fear is that the courts will decide instead of this body. And so I completely respect your opinion and respect our relationship together for all these years, but I feel like inaction is more detrimental than not. Thank you.
Okay, I have Chairman Gillespie.
Thank you, Madam Chair. Thank you, sponsor. we've been talking about this a lot, and it's my understanding this is the final calendar for this committee. Okay, so I have too many friends, too many family, too many people that I represent that are telling me before your amendment that you discussed with me yesterday was added, that they would flat out have to move to another state. I mean, it's just, that's what they're telling me. And it's extremely hard for me to ignore that when it's family, friends, physicians that are all telling me the same thing. So I certainly appreciate you getting this amendment in that alleviates a lot of those concerns. With that said, though, I'm still, because of the newness of the language and the amount of changes that it's made, I just can't feel comfortable voting for this even as amended right now. So I just wanted to say that to you. So thank you so much.
Thank you.
Is it Kumar or Cheryl that had a question?
Thank you, Madam Chair. Thank you, Representative Williams, for what you do. And hearing the testimony that the doctor testified a little bit ago, and understanding, and I don't understand it all. It's very critical, a very serious situation that we're talking about. To me, we're talking about a life, and I feel like what you're wanting to do, what I'm hearing, you're wanting to put some guardrails to protect what you're trying to do today, if I understand it right. And I just want to say I appreciate what you do, and still don't understand it all, but we definitely need to make sure we protect that life. Thank you.
Okay, Chairman Kumar.
Thank you, Madam Chair. Thank you again, Chairman Williams. I think the main roadblock to this bill at this time and the main concern is genetic testing. In your discussions with a lot of people and professionals and our constituents, did you come across a concern that genetic testing is critically needed, and what this bill offers is restrictive to their efforts at having a child?
Thank you. Currently, there are no restrictions on genetic testing. So this would incorporate those that are fetal-fatal anomaly or chromosomal deficiencies or anomalies. Most of the people that I talk to as it relates to this, obviously, if they're currently providing those services and they're discarding embryos in order to do it based upon that data or evidence, then that's the current practice that's there now, and has been the current practice for 40 years. Obviously, change is always difficult and different. What I've tried to do is to mirror language based upon common practice, and also take into consideration what would naturally occur in childbirth. Most of the people, there are, for instance, is a physician that I spoke to in North Carolina, and one that I spoke to in Farragut, Tennessee, and they practice ART or IVF, and they never freeze an embryo. They simply implant those as soon as they possibly can during the next ovulation cycle. And in some instances, they don't do any genetic testing of it because of their view of ART and IVF. On the other spectrum, you have those who have fertilized multiple embryos, do testing, freeze and long-term storage. And so there's a huge divergence of what individuals believe to be as best practice, but all fall within the CDC minimum standard guidelines that this bill sets forth. And so I'm not sure that I can speak to every person and their personal view, but there are, what I did hear from them was a real clear, concise desire to do the testing that we have incorporated here. And when I can do that, I will, based upon what's going forward. And my fear is if we don't act, then we're going to end up with these decisions being forced upon us by someone other than us, and without the discussion that we've had here today.
Well, thank you. In your discussion with the two extremes where people practice differently, do you think this bill will interfere with either of those practices?
Thank you, Chair Lady. I think that the only place that this may interfere with a current practice would be two areas. One, the bond requirement that is a little bit of additional cost for those in order to make sure that the laboratory is and those investments by these parents are protected. And two, the just lost my train of thought. Oh, was the testing in and of itself. I think those are the two differences. And some are not doing the testing, but I feel like that I've gotten as much testing in this language as I can from a genetic and chromosomal standpoint.
Thank you. Thank you, Chair Lady.
Okay. I think we have Representative Travis is next. No? Oh. Yeah. Okay. Okay, we have a question on the bill. All in favor, say aye.
Aye.
Well, there was an objection.
Right. So not yet. So there was question called on the bill. So all in favor? Board for it? Okay, Madam Clerk, you care to open? Yeah, we're voting on the question by Chairman Clements. Yes. Madam Clerk, would you please announce the vote?
Madam Chair, you have 10 ayes, 0 noes.
Okay, thank you. Okay, now we are going to vote on the bill. So Madam Clerk, would you open up the board? Did everyone vote? Did anyone want to change their vote? Okay, Madam Clerk, would you please announce?
Madam Chair, you have 4 ayes, 6 noes.
Okay, House Bill 0014, no, wait a minute, I'm sorry. I'd already turned it. 0945 fails.
Thank you, Chairman, Chair Lady, members.
Thank you. Okay, we've got one more bill. Thank you, Representative Love, for being so patient. We have House Bill 00. We're not dismissed. We're not dismissed. We have one more bill by Representative Love, 0014. You have a motion? Do we have a second? Okay, your bill is properly before us. Would you like to give us a brief description of your bill?
Well, I'll say this, Madam Chair. Thank you so much. I was before you last year, and I think by the robust discussion you just had, it brings up the fact that we need to verify and put in code that use of contraceptives and IVF treatments are not abortion. And that is simply what this legislation does.
Okay, does anyone have any questions for the sponsor? None? Okay, are we ready to vote? Madam Clerk, would you please open the vote, please? Has everyone voted? And does anyone wish to change their vote? Okay, Madam Clerk, would you please announce the vote?
Madam Chair, you have 2 ayes, 7 noes, 1 present not voting.
Okay, House Bill 14 fails.
Thank you, Madam
This
Chair,
time,
committee
I'd
members.
like to thank everyone for being here and everyone that testified. And population health is now closed, subject to the call of the chair.
Good job.